Okay, my name is Harvey Feenstra. I've been practicing chiropractic for 42 years, and I saw some of the old timers in chiropractic. I sat in seminars with Dr. D. Jarnett, and especially with Dr. Mel Reese, who got me interested in this temporal-sphenoidal reflexes. And those of you in SOT are familiar with the CMRT and the visceral reflexes. We correlated them with the occipit and the occipital reflexes, and Mel Reese correlated those with the temporal-sphenoidal reflexes. Well, I took a course in foot reflexology that correlates the reflexes of the foot with this as well. And I understand you can even find these reflexes in the ears. So there's a pattern of cellular activity throughout the body that relates to what's going on inside. And so my presentation today here is to show you what I've done and what kind of results that we've had with it. Integrating TS reflexes, sacro-occipital procedures, and reflexology for the treatment of chronic cervical pain and reduced range of motion. One of the things, louder? One of the things that Medicare wants for their proofs is range of motion, and workman's comp likes to see range of motion changes as well. So it's a good indicator of effective treatment. These charts show the TS reflexes on the left there, and the range of motions, and then the reflexes on the feet. We know that neck pain is certainly common, especially when you're sitting by computers for hours on end. We have two cases that we want to present today. One, a 38-year-old female with chronic 17 years of neck pain. She was involved in a car accident. The other one is her husband, and he not only had problems with his neck, but also had problems with his right knee. Here's the basic range of motion that we use, and in addition to the right and lateral flexion and right and lateral rotation, full forward and backward extension, we do a squat, simple, with your knees open going down. And I find that helpful in determining a category as well. If a person can squat and go all the way down and the knees don't twist, I think you're pretty well dealing with a category 1. If that sacral iliac joint is hypermobile, they're going to twist. So that's another indicator to verify your categories. Initially, the patient is assessed for psoas muscle imbalance and category 2 findings, treated if found. I like to reduce the major skeletal muscle contractions and go to the feet, see if they're even, and I'll just tug on the short leg just to reduce the congestion in the hip. Go with your hands, see if one is short, tug on them, get them even. Sometimes you tug on them and then it's longer than the other one. At times both of them were a little short, so get them even. And that reduces a lot of the gross muscular distortions. Okay, now once you get to the cervical spine, you can do this cervical stair step to kind of isolate what level you're working at, what vertebral level you're working at. Also, you can do side bending And the side of restriction that doesn't bend as far, and it's not with rotation, it's strictly side bending, is the posterior side, and you go down that side and you'll find a very painful spot. And then you turn the head the other way, and then depending on what vertebra it is, let's say, for example, let's say it's right at vertebra 3. Well, we know from our charts that 3 relates to stomach and ileocecal. So the TS reflex for that would be on this side, but with the head turned, it's more acute when you turn the head. If you do it straight, you might not find it. When you turn the head, it brings it out. And then you hold contact, like is shown there, while you're rubbing there, and you rub it for about 10 seconds and have the patient cough. If they give a hard cough, this pain reflex goes away a lot quicker. Why is that? I think it's because you're correcting the subluxation from the internal outward, and we're trying to correct the subluxation from the outward inward, and when the two come together, you've got a full correction. And I think it's got to do with the thecosac restrictions, but I'm not sure about that, but that's my theory. Once the most painful cervical articular facet is identified, the head is turned to the opposite side. TS reflex points are palpated, searching for the most sensitive point. C3 would relate to either T4 or 5 or L1 as determined by the patient's sensitivity to palpation. The region of cervical vertebral congestion is held in the upward position with the head turned so that the TS reflex region is placed downward. With the head turned away from the posterior cervical side, have the patient look down towards their feet as the head is moved slightly into flexion while exhaling. A cervical adjustment is made as the patient moves their head upward and looks at the doctor's eyes while inhaling. If you want a beautiful cervical adjustment, you synchronize this. And you have them breathe out and look down. Eye movements are important with this. When they're looking down and they're breathing out, and then when they come up and have them look at you and then make your thrust, it just slips into place so simple. And I never found a cervical technique that works so nice. That's why I'm excited to share it with anybody who wants to listen. And SOT people appreciate it more than anybody else. There's the chart, which most of you are familiar with, showing the reflex association with the viscera. Here's the chart of the reflexes of the feet. The course I took was with Doug Holland of integrative, or rather advanced foot reflexology. And basically, I finish up this as my last thing I do with the patient. Let's say I find a stomach reflex or the cervical reflex. I would go to that spot on the foot, hold it and manipulate it, and then again have the patient cough. And something about coughing makes that thing go away. And it goes away a lot quicker. Normal reflexology treatment could go anywhere from 35 minutes to 45 minutes. Who wants to be working on feet for that long? Not me. But this is much faster. In the case of patient 1 following the first treatment, full cervical range motion was noted in all directions, and the presenting pain, 8 on a scale of 1 to 10, was reduced to just soreness. Patient in case number 2 received 11 treatments over a 3 to 4 week period of time. By the 11th office visit, the right lateral flexion was full, but instead of pain in the upper thoracic, 7 on a pain scale of 1 to 10, the discomfort was reduced to soreness. And here's a picture of Dr. Reese, who researched this and originally developed by Dr. DeJarnette. And this is also a picture of one of the earlier founders of reflexology. These case reports illustrate one patient who had chronic cervical spine pain with limited range of motion for 17 years and another for 6 months. Case 2, both responded favorably to SOT Category 2 treatment, TS reflex and foot reflexology, and cervical manipulation. Further research is indicated for a larger sample with control group and comparison interventions. You might think that this must take a lot of time. Actually, to learn it takes a lot of time. But once you do it, you go through it, and it doesn't take that much time. In fact, my normal patient visit is about 10 minutes. 10 minutes or maybe 15, and unless I run into something a little difficult. But I would encourage you to explore this, and especially the new students who are a little reluctant to adjust that neck. This is a very effective, slick way of adjusting the cervical spine, which is very easy on the patient. Thank you very much for your attention. So, my presentation today here is to show you what I've done and what kind of results that we've had with it. Integrating TS reflexes, sacro-occipital procedures, and reflexology for the treatment of chronic cervical pain and reduced range of motion. Did those with the temporal-sphenoidal reflexes. Well, I took a course in foot reflexology that correlates the reflexes of the foot with this as well. And I understand you can even find these reflexes in the ears. So there's a pattern of cellular activity throughout the body that relates to what's going on inside. And so, who got me interested in this temporal-sphenoidal reflexes. And those of you in SOT are familiar with the CMRT and the visceral reflexes. We correlated them with the occipit and the occipital reflexes, and Mel Reese correlated. Okay, my name is Harvey Feenstra. I've been practicing chiropractic for 42 years, and I saw some of the old timers in chiropractic. I sat in seminars with Dr. DeJarnette, and especially with Dr. Mel Reese. One of the things, louder, one of the things that Medicare wants for their proofs is range of motion, and workman's comp likes to see range of motion changes as well. So it's a good indicator of effective treatment.